Thanks for joining us for CDC's webinar today, Beating the Media Crush During a Crisis, hosted in collaboration with the Society for Healthcare Epidemiology of America as part of the Joint Outbreak Response Training Program. This webinar is the final webinar of the Effective Communication webinar series designed to train hospital epidemiologists in the interpersonal skills important in an outbreak situation. To find out more information about the program and hear recordings of the previous webinars, visit ortp.sheaonline.org. Questions can be submitted through the chat function and will be asked at the end of the presentation. Today's speaker is Taylor Wilson. Taylor Wilson is the Senior Media Relations Coordinator at Nebraska Medicine, managing the health system's social and traditional media marketing efforts. He also produces video content for the organization's YouTube channel and website. He was the primary spokesperson for both the University of Nebraska Medical Center, the hospital's academic partner, and Nebraska Medicine, while the hospital was caring for 3 Ebola patients in its biocontainment unit. He's been at the center for 6 years. Prior to that, he anchored the news at KPTM Fox 42 from 1999 through 2010. He also worked at the NBC affiliate KSNT in Topeka, Kansas, and the CBS affiliate KBIM in Roswell, New Mexico at the beginning of his broadcast career.
Okay. Yeah, thank you. I appreciate the introduction, and I'm happy to be here today and share the lessons learned while we cared for 3 patients with Ebola and monitored several patients subsequently in the months following caring for those 3 patients in late 2014. So before we get into the actual presentation, here are a few of the things that we hope you end up with once we've finished here in about an hour or so. These are really the goals for the presentation today. We hope we'll be able to identify the role of media relations during a crisis. Hopefully, most folks here listening today are either part of a media relations team or work with the media relations team or have access to a media relations team, because that type of organization and department is obviously very crucial while you're communicating during a crisis. We're also going to be describing the steps needed to ensure effective internal communication during a crisis. That is another aspect that you need to consider along with the external component. We'll be exploring strategies for preparing staff to communicate with external media outlets, how we prepare those folks to do it, how we've been preparing those folks to do it prior to the crisis actually taking place. And we'll be talking about tactics for managing external communication and all the media requests you are likely to receive during a crisis. So with that, I always have a small portion about handling internal communication before I get to the bulk of my presentation. I should make mention that internal communication is not one of my primary duties. As Media Relations Coordinator, one of my primary duties is to communicate with the media, to communicate externally on social media. But I do work closely with our folks who do handle internal communication, and I should make note that it's very important for the internal communications folks and external communications folks to work hand in hand. If I don't mention that enough during this presentation, please someone mention that to me, because that is very integral to successful communication, is having the internal communication team and external communication team working closely together. So internally, as far as communication goes, we started communicating to staff about a month before we received our first patient with Ebola, who was Dr. Rick Sacra. He arrived in early September of 2014. But we started communicating internally with our staff members to make them realize that it was possible we would receive patients with Ebola in the very near future, seeing as our colleagues at Emory were already starting to receive patients in August of 2014. So while we were talking about how we were going to communicate this with staff internally, I should mention that our communication team is included in leadership meetings discussing the direction this is going to be headed. So including the communication team in all aspects of planning for this is very important, so they know exactly what the plan is going to be. And this has just kind of been our practice at Nebraska Medicine for as long as I have been here and even before that. So we always want to be honest, open, and transparent with staff. And the reason for that is we want them to know what we know. We want them to not see anything that we know appearing externally in social media or traditional media. So we want to share it with them first. We want any crucial information, especially information regarding care of Ebola patients, to come from us and to be coming from us as soon as we are able to communicate it to them, because as you probably know, there are really no secrets nowadays, and what is internal can quickly be external, and that's why I mentioned earlier we want our internal communication to be parallel with our external communication. So as we're planning to receive these patients with Ebola, we're communicating this internally to our staff, and we're also doing the same thing in a variety of ways, which I'll touch on a little bit later, with traditional media and on social media as well. And like I just mentioned, we want our staff to receive this information from us before they read it online, before they see it in the news. They are an important part of our organization. We have, when you include med students and other students and all of the clinicians and all the other employees that work here at Nebraska Medicine and the University of Nebraska Medical Center, we probably have about 12,000 people that we're talking about. And so we're communicating with all of these people, and we want to make sure they hear it from us first. We don't want them to be out of the loop because they are obviously an important part of our team. So before Dr. Sakra left for Africa, we started working up some internal communication pieces that we knew were going to be important for our staff members and internally for our patients as they arrived here at Nebraska Medicine to receive care. So we did have a letter that went out to our patients that each nurse, when a patient became a patient in Nebraska Medicine, a nurse would hand-deliver these letters to patients explaining exactly what was happening, that we were about to receive a patient with Ebola, or we currently are caring for a patient with Ebola as time went on. So these letters were hand-delivered, and we wanted to make sure the patients had all the information as to why we were doing it, why we thought it was important to do it, why it was safe to be doing it, and we just wanted to arm them with as much information as possible. And at the same time, we wanted to arm our staff members with as much information as possible, because they would be our ambassadors in a way for the message that we would be sharing with them. These folks are on social media. These, like I said, there was a lot of them, and so we want them to know what we know and to have the proper information, to be armed with that information as they went about their daily work and as they were just regular citizens in the community. So what we did is we sent out, along with that letter to patients, internally we sent out a Q&A document to all of our employees explaining what we were doing, why we were doing it, when everything was going to be happening, why it was going to be safe, how we had prepared for this, how we were uniquely prepared to do this, and that was the first piece of information we provided them. We also had a memo from leadership explaining informally some of the things that were in the Q&A document, how it was time for us to step up, how we were honored to be able to do this, how we've been preparing for this. So this memo went out from our leadership to everyone here on staff. We also provided management at different levels with talking points. If there were questions that staff members had that maybe weren't answered in the Q&A document, we provided management with these talking points to arm them with information. And we also, I should mention at the same time, we were partnering with our Douglas County Health Department in providing answers to questions. And they had a hotline set up that people could call in from the general public and ask questions. And so we would provide answers to as many of those questions as we could come up with. If we got other questions throughout the course of caring for patients, we would add additional answers. And so that was another aspect of how we communicated, more of an external aspect, but also a document that we prepared that tried to answer any potential question anyone might have. And as this went on internally, we provided updates as often as necessary and as possible in our internal daily newsletters with weekly emails. Some of our leadership would do videos talking about what we were doing and updating everyone on the situation. So we really tried to keep our staff members as up to date as possible and not just think that they would see it in the media. We wanted them to hear it from us. So internally, as a result of all this, as time went on, we have comment portions on our newsletters, and we can read that elsewhere. And one of the things we definitely saw people who were commenting on other social media pages that worked at Nebraska Medicine and UNMC, there was a very favorable internal response for doing what we did. There was a sense of pride in our organization that we were able to provide this service when there were so few places in the country at this time that were able to do this. And so that was the overarching sentiment that arose out of our internal communication process, and of course the halo effect that was also shown in the external traditional media. One of the main issues that we had, at least after the first patient, is we had to dismiss a couple of individuals because there were some patient confidentiality issues with looking into the records of our first patient, people looking at them that shouldn't have been doing that. And we had some internal folks, some staff members who had to be dismissed because of this. That did hit the media. We did have to address that, but we addressed it quickly and transparently. And that was probably one of the downsides that happened. We maybe didn't communicate as well as we should at the beginning of this endeavor, that we know what happens when curiosity comes around. And we need to make sure as healthcare professionals that we curb that curiosity and don't have people looking at the healthcare records of people you shouldn't be looking at. And so as we went on, that was an internal piece of information that we continue to reiterate a little more firmly as time went on and we cared for more patients. Incidentally, after we passed out those letters to patients, we did not have any patients who asked to be transferred to other facilities. We didn't have anyone who, at least to my knowledge, had any extreme concerns with what we were doing. And so that was a positive of communicating our message internally to all the patients. And I should also mention that if we did have anyone who had questions, members of our leadership team were on standby to go to these patients' rooms and talk to them one-on-one to address their concerns. In fact, our hospital volumes were at all-time highs. While we were taking care of these patients with Ebola, we actually had another healthcare system in town that was having some issues with an insurer, and so we had an influx of patients coming our direction. Our trauma system expanded, and we had more patients coming in that way. So not only were we caring for patients with Ebola, we were caring for more patients than ever before during this time. And like I mentioned before, what is internal is external. The fact that we had a confidentiality breach with some patient information was mentioned at an employee forum as that patient was being released. A few hours later, even though we had not discussed this with media at this point, media already knew about it. They were asking us about it. So anything that happens internally has the potential and has a very large potential for being external very quickly, as we discovered. Okay, so that's my quick bit of information about how we communicated internally, and I'll be happy to expand on that once we conclude this presentation, if you would like to. I should mention that I work very closely with our internal communications director at the time. We live in the same neighborhood. That was super helpful. Our kids go to the same school. That was helpful. I can't emphasize enough how important it is that everyone on your communication team works very closely hand in hand, because the messages need to be similar, if not exactly the same, and they need to be shared at the same time as often as you possibly can. So let's talk about the external portion of things as we move on, just so I give you a little brief overview, as I touched on a little bit earlier. But we did care for 3 patients with Ebola, one in September of 2014. That's Dr. Rick Sacra on your left. He was a physician working in Liberia. He goes back regularly and still does that now that he has recovered. The middle patient is Ashoka Mukpo, seen with his father and his girlfriend at the time upon his release here from Nebraska Medicine. We received him in October of 2014. He recovered very quickly and is back at his job as a journalist. At the time, he was working for NBC News as a photojournalist with Dr. Nancy Snyderman. He had been partnered with them or hired by them just a few days prior to coming down with Ebola. So the fact that he was an NBC employee presented another unique wrinkle in our communication process. And our third patient was Dr. Martin Salia. He was a doctor in Sierra Leone during the time that he contracted Ebola. He had a couple of false negative reports before he came to us. He was extremely sick when he arrived in November of 2014, and he unfortunately passed away less than 48 hours later, succumbing to that disease. And in fact, tomorrow his wife and family will return to Nebraska Medicine for a special ceremony honoring him and his family for the sacrifices they made. We'll be putting up a plaque in our biocontainment unit. Our staff member feels a very close kinship to that family and views him as a hero for what he did and the sacrifices he made in caring for patients with Ebola. And so he was the third patient that we cared for in November of 2014. Subsequently, we also monitored patients with Ebola in December and in several months in early 2015. So this entire course of, quote, crisis communication went on for the better part of 6 months at the end of 2014 and 2015. We did receive hundreds of interview requests, especially heavy once it was announced that we would be receiving the first patient, Dr. Sacra. When it was all said and done, we had nearly 60,000 mentions of the name Nebraska Medicine, Nebraska Medical Center, UNMC online, on air, and in print. And we had a print and broadcast audience approaching 1 billion people. As many of you may know, monitoring numbers can be a little inexact, so those are the best numbers that I have. But needless to say, our name and our effort was receiving some high-profile attention during this time. We had national and local networks camping out on campus for days at a time. You can see those photos below. That was one of our first press conferences that we had to announce that we would be receiving a patient with Ebola. On the right was a tent city that was set up outside the building where we had the press conference. We had really an intense media rush happening virtually around the clock for weeks at a time. I would receive calls from the other side of the globe from media outlets wanting to conduct interviews at 4 a.m. I would get paged at all hours of the night and the day. It was an experience unlike any other. I've commented to many people, however, that after going through that, it's like swinging a weighted bat. Everything following that seems to be a little bit easier, but during that time it was quite the blur, and it was, as some people might call it, a media circus. We hope to keep that circus under at least one tent and not get it into several at that time. So 2 days before Dr. Sacra got here, we started talking about how we were going to communicate this, where were we going to have press set up, what was going to be the best place for everyone, for us, for the press. But I really think, looking back, there was a decision that was crucial to the success of our communication plan. And I don't say this to toot my own horn. I say this to emphasize to you how important it is to streamline your communications as much as possible. I've talked to other entities since then that have been somewhat amazed that we were able to be so flexible in our communication, that we didn't have to have dozens of people signing off on messages and had to have such an extensive review process before we could communicate something. So before Dr. Sacra got there, I think this really was the most important thing that happened. And I should also mention this was important because the University of Nebraska Medical Center and Nebraska Medicine, we are two separate entities, although we work very closely. We have two separate PR departments, so we sometimes have issues with them receiving calls that should be for us and vice versa. And so in our case, this was extremely important that we had a singular point of contact for all things related to Ebola. Everything that flowed into or out of our organization, our 12,000 people here on campus, came through me or went out through me. I was responsible for writing the media releases, for posting to Facebook, for tweeting, for monitoring social media, to responding on social media. Because I was just so close to the process, I think it was extremely important to have that one person who knew what the requests were, what the messages needed to be, and who the important people to share those messages were. So I sat in a meeting with the executives and members of the University of Nebraska Medical Center PR team. Our VP of Marketing at the time turned to me, said it was going to be me, and I said, let's go, let's do this. Looking back, I would have been a little bit more hesitant because it was quite the experience over these months, but it also was transformative in my career and in how I operated going forward. I'll backtrack a little bit and talk about our history here in crisis communication, because I think that's important to note, because you can't all of a sudden have a crisis happen at your organization and just send your crisis plan into action. And we all have crisis plans, I think, or we should, and it's important to build up to that. And I've been here for a little over 6 years now, and I was very lucky to have people who had laid a foundation prior to my arrival, who'd built up relationships in the media and built up relationships with clinicians in letting them have experience in talking to the media. So I always like to refer to this as the culture of proactivity, that when crisis comes calling, you often have information that that crisis is going to happen days, weeks, months before it does. It may or may not happen. It may not see the light of day, but I always like to say we have to be planned for as many things as we can plan for. So we always have messages prepared if something happens. So and we often have messages prepared if different things happen during the course of the crisis. And I'll touch on that a little bit later. So if it's not your way right now to be proactive, to start thinking about and start working on communication before the actual crisis is on your doorstep, that revolution within your organization has to start now, because once it hits you, it's often too late. The message will spiral out of control. It's very important that the leadership involves us in crucial communication decisions. We are often looped in on the things that are happening within the organization, and we know about these things just because we may need to communicate about them. They don't just involve us, they trust us, and they take our advice. They know I work with folks who've been in the media before, like the introduction mentioned. I've been in the media for a long time. Prior to this, I work with folks who've been there. They know, we still know how the media will operate and what they will need, and so our leadership takes our advice, and it's very helpful in allowing us to do our job, basically, because they trust us. We are known throughout the organization that there is a department that does what we do, and that if something needs to be communicated, they will come to us. Internal communications that we put out informed everyone on campus that they shouldn't be just responding to media questions should they get them, that those questions should be handled through my office and more specifically by me. So you'll want to prepare the people, and if you are the people, you'll want to prepare to be able to communicate to the media. We have sessions where we will sit down with our experts and ask them mock questions, put them in front of a camera, and ask them what they would do in this situation, act like they are being interviewed by the media. And so we did this a little bit during this time, but prior to this, our experts, our epidemiologists, our healthcare professionals, infectious disease professionals, a lot of them had already done extensive media interviews. So they knew what to expect. Now needless to say, the glare of the spotlight was a little brighter this time, but they've been on camera and they've been interviewed. And so that's helpful. Doesn't matter how big or small those interviews are. If it's you, find opportunities to do it. If you're a communications professional, find opportunities for your folks to do these interviews, so when the time comes, they are not completely unfamiliar with the process. So for years, infectious diseases specialists have been in front of our cameras, locally at least. TV station with a large audience will call and say, we want to talk to someone about effective ways to wash your hands. Seems like kind of a waste of time, perhaps for a person who's very busy seeing patients. Fortunately, our folks don't view it that way. I've talked to Dr. Mark Rupp, who is one of our leaders in infection control here at Nebraska Medicine, and he learned a long time ago, and he tells me this regularly, that he views it as his duty to inform the public about certain things like this. He's looked at it that way for a long time, and it's part of his job, And so anytime I call him with interview requests, he's usually my first call that I make because I know he's reliable, I know he is up for doing it. So if it's about hand washing, if it's a large TV viewing audience, we'll say, sure, we can help you with that. TV station that has hardly any viewing audience wants to test cell phones for strange bacteria. They're doing a story on what lurks on your cell phones. We'll say, sure, we can help you with that. We have a disinfecting robot. Newspaper wants to do a story on that. Sure, we can help you with that. A radio station wants to interview someone about STDs. Sure, we can help you with that. Not only does it provide community goodwill, it gets our experts in the eyes of the public, talking about things the public does care about. It prepares them. Indirectly, they're doing interviews. They're on camera. They're being quoted. They're being interviewed by reporters. And it was certainly helpful for us while we were caring for patients with Ebola. Now, we obviously did have to select several people to be our, quote, spokespeople during this crisis. Quote, I say, quote, crisis, because I don't like to consider it a crisis because I think we kept it away from that level, but everyone calls it crisis communication, so that's what we'll refer to it as. But aside from myself, I did do a few interviews, but I always think it's best for the experts to speak when they can. People want to hear from the people on the front lines. And fortunately, we had a lot of people who were able to pitch in this regard. We took our entire team because, as I discovered, and this was something I hadn't discovered or even thought about before this all took place, that media burnout is real. We had so many requests that I couldn't keep going back to Dr. Phil Smith, who was the medical director of our biocontainment unit at the time, or Dr. Angela Hewlett, who was the associate medical director of the unit at the time. I couldn't keep going back to them, although they were the most knowledgeable in most ways, and they were on the front lines, and they were providing the patient care. I just couldn't keep going back to them. There certainly wasn't time, and we had so many requests. So we had to assemble a team of people who were reliable, who were knowledgeable, and who were willing to help out. And we were able to recruit as many people as possible. We probably had 6 or 7 folks who I know were able to help out, depending on the outlet that was asking for an interview. These requests, like I said, were relentless. They, especially as new patients would arrive in the early stages of this, the news was, quote, new, and you had to prioritize those requests as quickly as possible. I made a list of every single one, and I started assigning people to those and finding out who could do what and when they could do it. I also should mention that the best spokesperson isn't always the head of your department. You may have a person who's excellent at their job, but either doesn't want to be on camera or isn't comfortable being on camera or just doesn't portray the organization that well on camera. Fortunately, we had great people here, but you don't need to go to the top to find your spokesperson. Sometimes you have people who are very capable, very willing, very good at doing what they do, and they may just be another person who is a part of your team of people that are helping out during your crisis. So I mentioned a flood of requests, and we certainly had that, especially when Dr. Saker arrived. We were probably a lot more fortunate than Emory was. Emory had the first 2 patients, and it was new and novel. Still was somewhat new and novel in early September, especially locally, but we still had calls, texts, and emails coming by the dozens, if not the hundreds. The communications we started sending out had my phone number and my email, and so my phone literally heated up in my pocket. I could feel the heat coming off my phone from all the texts, emails, everything that was happening because it was such a relentless flood of requests. So what I did was I triaged the importance of these requests. I looked at all the people who were asking for interviews, and I made that list. And obviously you're going to have to pay attention more closely to a cable news network than a small radio station in Binghamton, New York. But I definitely responded to every single person who requested something, and I tried to provide an interview or information, if it was just information, to everyone who emailed, texted, or called me. I had that established list of who was available, when they were available, and another point that seems kind of silly, but Initially, I was a little shaky in this regard, but you had to have a firm grasp of technology, and I am something of a technophile, so I disappointed myself a little bit early in this process, but I had to have everything I needed everywhere I was going to be, every time I was going to be there. So in other words, I was spending a lot of time at work, but when I was at home, I had to have access to everything I needed. I had to be able to email anyone at any time. I had to be able to have my contact list there. I did phone interviews at home. I had to make sure everything, all the information I had was everywhere I was going to be. What was on my tablet, my phone, my desktop. So as a communication expert, no matter where you are, make sure you've got everything you need. And another side note I will make to communication experts if you're listening today, it's easy to forget the local media when something like this happens. When national media is all of a sudden clamoring for interview requests, and we were talking to Kate Snow, who was here. She works for NBC and is with the crew covering Ashoka Mukpo, who was our second patient. When you're talking to her and you're seeing people who've been on television that you've watched for years, it's easy to forget these local folks who you have great relationships with when the national media isn't here. So I make an emphasis, I make a note to say, don't forget your local media. Help them out like you always would. So what do your experts need to know when this crisis happens? What do they need to know from you? And if you are the experts, these are the things I think are very important that you know if you're going to be communicating in a time of crisis. Proactivity is an absolute must, like I mentioned before. We've got to be ahead of everything that's going to happen. When we hear something's going to happen or something potentially might happen, we have to start working on messages. We have to start thinking about who is going to be our spokespeople. We have to think about where we're going to have these press conferences, and you have to have contingency plans built in for things like that. We have a crisis communication plan. We have several locations on campus that we have determined we would use in the event that TV stations show up and need to park trucks, or there are large numbers of media. In our case, 3 of those places that we had established were no longer available due to construction on campus and other events going on. So we had to have Plan D to make that happen. So we already had the first 3 plans, so we went straight to the next one and made it work out that way. Another thing experts need to know is we can't say no comment today. We can't just start caring for the patient in our situation if we're in healthcare. And if it's a high-profile patient, we can't just say no comment, we'll tell you about that later. Because what happens when we do that and we don't have a message to share, messages get created. Speculation starts to happen. False information starts getting shared. And all of a sudden, in a situation where we should be able to take the lead, we are starting to play catch-up. And so we can't say no comment. That just can't be something we do. Even in the case of a patient you may have that you can't share information about because you don't have a release form signed, and we were fairly fortunate in that regard because we had release forms signed on our patients fairly early in the process, and I know Emory was not as fortunate as we were, so that does tie your hands to some degree. But there are things you can say, and there are messages you can communicate, and you can have press conferences, and we did that even before Dr. Sakra arrived. As I kind of alluded to, you can't put your head in the sand. I can think of instances locally where organizations have had it made clear that local media outlets are investigating them for one thing or another. They've been given the opportunity to comment about the story these media outlets are working on, and it was clear that they said no comment, put their head in the sand, and hoped it would go away. Well, obviously that doesn't happen. The story comes out without any input from your organization, and at that point you're playing catch up. The media outlet may allow you to respond a couple days after they've already published their 3-day investigative piece, but at that point it won't even matter because the public has already made an opinion, informed an opinion about the story. So the bottom line is you have to be available You have to be willing to provide updated information according to the daily media appetite. Availability is so important. I can't tell you how many times I had members of the national media be stunned when I would respond to a text or an email within 5 minutes after receiving it. That told me, and in fact I had several folks tell me that I can't believe how responsive you were. Now I may not be able to help them immediately, but I can at least let them know that I saw your message, that I'm going to help you, or I'm going to try to help you and provide you with the information you're looking for. And you have to be willing to provide updated information according to the daily media appetite. That's kind of a phrase I made up because you could just see it happening during this process. You'd have an event happen, a patient would arrive, the media appetite is, they're hungry for new information. And they're hungry for new information hour by hour, minute by minute. As the situation unfolds and they start looking at other things going on, other sidebars, that media appetite would die down a little bit. But then again, something would happen. The nurses in Dallas contracted Ebola. That spiked the appetite again. They wanted more information. And so we had to be able to pay attention to what that appetite was and provide information as quickly as we could, as responsively as we could, as accurately as we could, in every instance, or as I mentioned before, the message starts to not be yours anymore. So what do journalists want when they're hungry for new information? They want something new, anything that no one's seen before, that's a piece of information that they can share on their broadcasts. It can be as very simple. It can be something like that photo in the bottom left. Dr. Sakra is obviously recovering. Dr. Hewlett gave him a Nebraska Huskers t-shirt. His wife, who was in the patient hospitality room, talking by webcam with him, took a picture, and I was really close to her at the time. I said, hey, can we share that? Media would love that. Yeah. So that was a new piece of information. Of course, that went out on social media like wildfire, like you wouldn't believe. They want content that's readily available. When this all started unfolding, we already had photos and video from our biocontainment unit, from drills that have been happening 10 years prior to the arrival of our first patient. We had that online in a Dropbox link. Once the media started asking about, do you have pictures of this unit? Do you have interviews of the people in the unit, a video of them working in the unit? We sure do. Email them a link and they have it moments later. Staffs are smaller than they used to be. It's harder for them to cover stories, and so you have to make it as easy as possible for them to cover your story. It's very helpful in their process, and it's helpful in your process too. Anything that seems like insider information is something journalists want. The little thing on the dry erase board up there in the top right, that was when Ashoka was being dismissed. Nebraska 2, Ebola 0. That was a fun little piece of information we were able to share in a release and subsequently on social media. And they want exclusive interviews. Now, sometimes that's hard to provide because everyone's asking for the same thing. And when they're all asking for the same thing, it doesn't make sense for our experts to go from place to place to place and do multiple interviews. So when that's happening, we set up press conferences, and we probably had 10 to 12 press conferences throughout the process of this. But they can get exclusive interviews, and I always tell reporters this, if you ask the right questions. We have a local TV station and a local newspaper who would ask questions that we could help with. They were questions that we weren't really talking about widely, but it was information we could share, and we could provide them with these exclusive interviews. And in turn, they ended up with great stories. The newspaper ended up with some stories that no one else had, and so did one of the local TV stations. In the bottom right, I should mention, this is we started taking video of the arrival of patients. We put that up on a Dropbox link, so stations that weren't here locally could download that video and use it on the newscast. And through our media monitoring, we saw a lot of that was actually being used. Answering tough questions is one thing we need to think about. It's important for a communication expert such as myself to be physically close to the people who are providing the care. So it doesn't matter what the crisis is, your communications professional has to be physically close to the people in the midst of the crisis. They have to be able to see you. You have to be able to see them. You have to be able to access them and tell them, okay, here are the interviews that I have available. Here's the ones I would like some help with. Can you help me with this one? Who else can help me with this? So I would set up my laptop in our incident command center, which is that photo of Dr. Smith below. That is showing that incident command center, a little slice of it. I'd set up there, and for days at a time, I would talk to the nurses who'd come back in from caring for patients, talk to the doctors. So I got to know them. And so not only was I physically close to them, I was emotionally close to them. They trusted me. I knew them. I saw what they were going through. That was so helpful for me to not just hound them for information or hound them to do an interview. I could feel the tone of things. I could tell when it was appropriate and when I could ask them about certain things. If you're one of those experts on camera, I've always told them it's okay to say I don't know. You don't have to make something up. You can say I don't know, but I'll try to get that information for you a little bit later off camera. Catch me here in a second and we'll find that for you. It's okay to say I can't share that right now. If your patient hasn't signed a release form, there is a lot you can't share. And so it's okay to say that you can't share information right now. We had our first patient being treated with an experimental drug. We had a confidentiality agreement with that company that didn't allow us early on to say what company and what drug it was. So we couldn't share that information. That became a point of contention on social media for people who were investing in this drug, but it was something we just could not talk about. And a culture of transparency establishes goodwill. If you're open in sharing information with the media, open in sharing your message on your social media channels, communicating on other media outlets, social media pages where people are making crazy statements or asking questions, where it shows that you are invested and you're there providing answers, that transparency establishes goodwill. You get closer to your people you're working with in the media. They know that you're there for them. You know what they're like. It's especially true with local media because you work with them all the time. National media, that can take a little bit longer. One thing I did realize very quickly that I would conduct an interview on the phone with a national newspaper, and 2 minutes later, my quotes were in cyberspace in a story or on Twitter or on Facebook. So you have to realize that very quickly the tough questions that you're answering are going to be online and out there for everyone to see. That's something that you don't deal with as much when you're speaking to local media. Like I mentioned before, you have to have contingency plans. When Dr. Salia was coming, we had no release form signed. He was very touch and go. I was in close communication with Dr. Smith throughout this process. He was calling me in the middle of the night to update me on his status so we knew which way things were going to turn. We had messages created in the instance that he would pass away or the instance that he was continuing to improve. So we had to rapidly vet these messages among our team members. We had texting chains, about 10 people, all the highest level people looking at messages in this case. I didn't mention before, but other times we'd share messages, news releases, social media posts. I was given kind of the keys to the car to be able to communicate quickly and effectively because I was close to the patients' families. I knew what the information they wanted to share, and so that allowed us to be very flexible in creating, vetting, and disseminating our messages. And as I mentioned there, it's important not to just be close to the experts, and it was very important for me to be close to the patients and their family members. There you see me with Dr. Saker upon his release. I obviously didn't get to know him as well as his wife because he was in isolation. I would see his wife every day. She would come visit the hospitality room where she could talk to her husband. We'd just sit down and talk about what was going on with him, what she wanted to share, what she didn't want to share. We'd get together with members of his medical team, and then we would create a message based on an update, a daily update. Here's how he's doing. Dr. Saker had a local Omaha steak provided by X Steakhouse. He's getting better. He rode his bicycle today. He's getting bored. He's playing chess with the staff. So I was close to family members, as close as I could be, and that lets them know that you're there to help them and you're a resource for them. And you have to be frequent and relevant with your messaging. You can't just say, "Woo, I got that one out of the way. Now I can sit back and relax a little bit." As I said, that daily media appetite doesn't allow for that. So you have to communicate as frequent as that appetite is asking for, and it has to be relevant. I mentioned earlier the Dallas nurses who contracted Ebola. On that day when that happened, I pulled together some of our nurses and nurse managers in the unit and said, I think we need to talk about how our nurses feel about this, expressing their sadness about what's happened in Dallas because these folks didn't have the same training or tools that we did, and talk about why our situation is different for our nurses. And so that day we did that. We shared it at the time. Facebook Live wasn't really a thing, so we used some other methods to do some live streaming, but several national networks caught the live stream of our impromptu news conference involving our nurses and shared that in the days to come on national news networks. So I mentioned mock interviews earlier. When you do this, you have to think like a reporter. If you know some reporters or if you have media experience, you have to sit these folks down and you have to ask them those questions that you think the media is going to ask. You have to talk to your experts and let them know that brevity is beautiful. It's so much better than a run-on sentence that will be cut off and the meaning may be misinterpreted. Keep your thoughts short, keep your sentences short, and that will be a big help to you down the road. Fortunately, our folks, like I said, had a lot of experience with this, and I really could not have been prouder of the way that our folks performed in the spotlight. My wife would tell me, and she would watch our news conferences and just make mention of how eloquent our people were and how heartfelt their messages were. And I said, that's exactly how I feel. They're real people, and they're showing that they're real people, and that's why compassion is king. Showing that they're real people, and they were close to these patients, that they hurt when Dr. Salia passed away because I still see it in their faces to this day. I told them it's okay to be a person. You don't have to be a robot in front of the camera. Just be who you are, and everything will be fine. And fortunately, we had a bunch of Nebraskans who are, compassionate, great people, and I had that on my side throughout this process. And we do have some practice sessions. We've had practice sessions since then, in case something else happens down the road. We have the people we know we can rely upon and who are prepared to do something like this, because practice, although it may not be real, certainly does help. Failing in the spotlight, as I mentioned, if you start working the messages when the questions already are there, you got a problem. If no one's there to answer those questions, that's a problem. That's why when I knew a lot of times when we had our medical experts were tied up and we needed to do an interview, because I was so close to the situation, if I knew the subject matter well enough, I would provide the outlet for the interview myself. If there are media releases that had important details omitted, that's a problem. I can't remember specifically, but I think there was at least one time when I wrote a release and there was something that had been omitted, and I immediately got a flood of response emails from my 300 or so people who were on the list asking, wait, what about this? So all that information needs to be in there. And failing to respond in a timely fashion, you can't just wait. People want to know that you see them, you hear them, you're going to help them. And once they know that, half the battle is won. So as we wrap up here, I guess we're got a few minutes over, but be proactive, prepare your people, get them ready, be open, be honest, be transparent, internally and externally. Once you know something and you can share it as soon as you can. Find that singular point of contact. That's what worked well for us. Other organizations may have different structures, but in our situation, it was certainly helpful to have one person where everything could flow through them. Make sure everyone knows who that person is. Best spokesperson is not always the leadership, the head of your department, and be available. Be there to provide those daily media updates or hourly media updates depending on that daily media appetite. So with that, I will turn it over for questions. Again, I'm happy to answer anything about internal or external communications, and if I don't know the answer, I will say, I don't know.
So Taylor, thank you for that great overview. We have a ton of questions, and so one of the first questions is, so you were the sole contact, but there were instances, obviously, when you had the medical, the clinician speaking. Were there other individuals in the organization that you sometimes had speak as well?
Yes. So like I said, we had our medical director of the biocontainment unit, Dr. Smith. He was the gentleman who had the idea for the biocontainment unit in 2005 using some Homeland Security money. He was often a spokesperson and probably was at every press conference. Associate medical director, Dr. Hewlett, who is now the medical director of the unit. She was outstanding for us. She just couldn't have been better on camera and more willing to help. And as far as that goes, all of them were willing to help. In addition to them, we had infectious disease specialists who were on standby, who knew about Ebola and could answer questions about Ebola and this situation, even though they may have not been providing hands-on care. So we had Dr. Mark Rupp, who like I said, turned to for interviews for years for things about hand washing, but now we're talking about Ebola. Dr. Brad Bridigan, who is the Dean of UNMC's College of Medicine, but also just happens to be an infectious disease specialist, which was certainly very helpful. Dr. Allison Freifeld, who is also an infectious disease specialist. She was helpful in several instances doing interviews with some outlets. We just had a number of people, people who were just on the front lines, nurses who were in the unit who'd been in with one of the patients, did webcam interviews with some TV stations. So we had a steady stream of experts, but then we had other people who, I would say to the nurse manager of the unit, I would say, here's the type of person I need for this kind of interview. Who do we have? And so we would turn to those folks in those times. So, but we had a lot of people who were willing to pitch in.
So, I'm also wondering, what you described sounds like a Herculean task, and I'm just wondering, how did you actually protect yourself? Since you were the sole point of contact, you needed to sleep sometimes. So how did you manage all of that?
Yeah, it's, like I said, the ability to have all the information everywhere I was helpful, because I could go home, sometimes at a regular hour, sometimes not, but I still had everything I needed. I still had all my contacts, I still had all my text messages, I was in contact with everyone, I could do phone interviews, which I did very often in the dining room of my house. At some point, you obviously do need to go to sleep, and so I did, but I would get awoken by our calling service saying, yeah, you've got a page from Al Jazeera wanting to talk to someone, and it will be 4 in the morning. Now, in that instance, I would talk to that person and say I would try to get something when I'm awake, and let them know what time it was in Nebraska. But for the most part, it wasn't unmanageable. At least looking back, I don't think it was, if I had to do it again. And I think we were fortunate in the regard that we weren't the first. I'm fairly confident in saying the media scrutiny and rush at Emory was much worse than what we saw.
So there was another question. Did you identify a media staging area, and if so, where? And did the media actually stay in that area?
Yes, mostly. Like I said, the 3 places we were going to use were not usable for one reason or another. So I actually found a building I'd never even been in on campus until this all started. It was really a perfect location. That photo that I shared of the media setting up, it was a large room that had internet connectivity. That's important. The room has to have room for a dozen or so tripods to set up. It had an audio capability in there, so all the folks all the TV folks and radio folks could plug into what we call a mult box, so they could receive the audio from that room. We had audio technicians helping out, and I should mention that our PR team here at Nebraska Medicine and the same at UNMC was just at my beck and call. They knew I was the head of the effort, but anytime I needed help with something, they were there by my side providing anything I needed. From as small as this, like I said, it was a new building, so we had people traipsing mud in, and so the manager of the building wanted carpets put down. So I asked someone to put carpets down. And so something as small as that, we had a great team that helped out. But internet connectivity, a lot of space is important, good lighting is important, and it was also important, we had a patio right outside where they could set up and have the campus as a backdrop. And so we wanted to provide a good view of campus from there. That was helpful. We didn't want it to be too close to the area in which the patients were receiving care, and so it was kind of on the edge of campus, and it provides that gathering point. It's a home base for the media, and at a hospital, you don't want people wandering around too much. Obviously, having said that, you have newspaper reporters who are not carrying cameras on their shoulders. They're free to walk around and ask any questions they want. We had, I remember a Boston Globe reporter did just that and talked to employees on campus about how they felt about all this. So we certainly don't attempt to corral people, but we provide areas of interest to focus them on places where we would like them to be. Like when patients arrive, we tell them where the best view is going to be, where you can get your pictures and video, and so now they know that's the place they're going to be. They're not going to end up being somewhere else that they shouldn't be, and so we try to provide those places that are best for them and best for us.
So did you have any issues with employees talking to media without authorization, and if so, how did you handle those situations?
Like I said, we had the Boston Globe reporter wandering around, and if I remember correctly, I think he spoke to a few med students. So, and they had no concerns, so in that regard, we were fortunate. We did have one incident, I think it was the second patient, where I speak so boldly about all these contingency plans that we have, and we had contingency plans in place, but I got a call from a local TV station basically telling me what I already knew, even though no one else knew it. So I have my suspicions. I think there are folks within the organization who are close to people in the media, and so they're maybe tipping them off about what they may have heard. And so in that regard, our hands were a little bit tied in the situation because we didn't have confirmation that the patient was indeed going to be transported, because if they're too sick to be transported, then they may not come. So we were still kind of in a limbo position as to whether they were or they weren't. The local TV station heard they were coming. They were running with that information, so we had to scramble a little bit and get definitive information that patient was going to be coming as soon as we could. And in the meantime, we had to adjust our language, talking about there's a possibility, we don't know yet. So flexibility was important there.
And there's a question about how did you handle the messaging regarding the employees who were dismissed due to violating HIPAA? And this person is especially interested in the human resources aspect of this.
Yeah, we didn't name those people. I believe that if I remember correctly, we did name the number of people. It was probably under 6, if I remember correctly. It may have been even half that. I can't say for sure. But once I received word that this had happened, we talked about how serious we take this. It's something we don't tolerate. It's something especially we can't tolerate in this instance, that we will be reiterating to staff members that patient privacy is at the top of our concerns, and we just made it clear that it was a serious situation, and we're committed to making sure it didn't happen again.
Okay, there's a question about dealing with incorrect information on social media and the fact that there are often a lot of difficult comments afterwards. People sometimes make comments that are just incorrect.
Right.
How do you deal with that?
Well, that was in my downtime. What I had of it, I would peruse the local media Facebook pages. We're always monitoring Twitter and seeing where we're being mentioned. But anytime I knew there was going to be a story, I would bring up all the Facebook pages and look and see what the conversation was looking like. Was there good information out there? And one of the side effects of having good information being disseminated is that local residents are armed with this good information. They already have it. And so in many cases, anytime a statement was made that was erroneous, we had members of the public who were jumping in and saying, no, that's not the case. Here are the facts. If I felt like the conversation was getting sideways a little bit, I, as Nebraska Medicine, would enter the conversation on these social media pages, just sharing the facts. And I think I mentioned earlier that I think that just kind of lends credibility to your message. If you're out there in cyberspace showing that you care and that you want to make sure the correct message is shared, you're out there doing that. As time went on, I feel like we had more and more ambassadors sharing the correct message about what was taking place. So I didn't have to do as much of that. And I think we were pretty fortunate here in Omaha that we didn't have a whole lot of that. We have a lot of community pride that surrounds the Med Center, and so I think there was a lot of pride in what we were doing. And so the folks who were making misstatements were either corrected by us or by other members of the public.
So we have there's a lot of questions on a number of different topics, and hopefully we can get to all of them. But one of the questions that came up is regarding how quickly to answer a question, because it says at the onset of an emergency, is there concern the initial information you put out is inaccurate, or that you'll have to clarify your statement later on? You stated that it's important to respond quickly, but how do you balance responding quickly with making sure that the information that you get out is as complete and accurate as possible?
I think the closeness to the experts is really important in responding quickly and accurately. Like I said, I was often sitting right next to the people who were providing care, who were in the middle of this crisis, who knew the answers to these questions. And so because I was close to them, I could simply ask them person to person, what's going on? What's happening? What's the situation? If I was getting conflicting information, then obviously I wouldn't share something until I had confirmation of what was taking place. But that closeness to the people was very helpful.
Okay. And did you experience any tension between responding quickly to questions and getting responses cleared by leadership or by lawyers?
See, and that's the area in which we were very fortunate. And they trusted us to do our job, trusted me to do my job. And there were certain conversations that I got into on social media that I learned fairly quickly that was really a pointless argument. And I referenced the folks who were invested in the experimental drugs, who wanted to know for sure what it was, because I eventually learned, well, their sole motivation was to have the stock price of their drug that they were invested in go up. And so arguing with them as to why I can't share the name of the drug was pointless. So there are certain arguments that I didn't get into, and you learned which ones to enter into and which ones not to. But our culture here on campus has always been one that allows the media relations folks to be very open in their communications and to do their jobs. I know in a lot of places structure is different, and there are times here on campus where there are things that attorneys do enter into, and the communication is not the same as it would be in other instances. Or if you're working with other entities, when we were monitoring patients, that was a little bit different than when we were caring for them. But on the whole, I was fortunate that I was allowed to do my job and that they trusted me not to, quote, be stupid.
So, one of the questions always is how to handle more routine situations in hospital. So in this particular situation, this is an exotic communicable disease. Do you use the same communication strategy for scary non-lethal pathogens or for other serious but more common newsworthy events, or something like a norovirus outbreak in the hospital or any other hospital outbreak?
Yeah, I think our communication effort would be similar, just scaled down. We have, crises on campus that happen from time to time. We have just a few months ago, they were working in a parking garage and some paint fumes pooled in an area, and people got lightheaded, and they had to evacuate part of the hospital because of this. Well, that's a crisis when you're moving patients out of their beds and moving people out of clinics. But we do the same thing we've always done. We have a point of contact with the media. I or a colleague of mine will go on site where the crisis is taking place, letting the media know where the staging area is going to be, where the questions are going to be answered. At the same time, we're listening. We have an incident command where folks are talking on the phone in real time about what's happening with the, quote, crisis. And so if there's a need for a press conference at some point, we would pull that together. But it's a very similar process. Media wants to talk about what's happening. I'm listening information in real time, I'm confirming that with the folks in Incident Command, making sure we can share X, and I will say, okay, here's what I'm going to talk to the media about, here are the questions, are we good with this, yes or no? And so then I will, kind of call an impromptu press conference on the street corner and do an interview right there. And that's, kind of what I've been hired to do, is to, if there's a time when we don't have other people available, that that I will field those questions. And it's very helpful to media when they have someone to talk to. Often they just need someone to talk to. They're on scene, they've got video of what's happening, but if they don't have you to talk to, they're going to start searching around for random people to talk to, and that's not a good thing. But they still may do it anyway. I'm not saying this is foolproof, but it really is just a scaled-down version of what we did with Ebola.
So one of the questions that came up is, did you have to confirm the credentials of those placing media requests, and how did you do that?
That's a good question. I mean, often, and in most cases, the points of contact I would receive initially were via email. So you could look at the email address and say, ron.allen at NBC, You could see that these people were who they said they were. A lot of people, it was in person. I can't think too often that I just got a random text, at least initially, and phone calls the same way. I mean, it usually started off with email, then I had an email list that I sent everything to. So as far as confirming media credentials, that wasn't something we really had to deal with, nor do I think we really had an issue with that. I have some foggy memory of somebody asking questions. I think it went back to the experimental drugs. There was, and I can't even remember who it was, but there were some questions where you could tell something just didn't smell right. But in general, that wasn't much of an issue.
So what criteria did you use to prioritize requests from the media?
Well, it's, being in the media, you get to know names and know outlets and know who's what. And so when the media spotlight is shining on you from a national perspective, I think when you see CNN and you see MSNBC and you see Fox News, you see NBC Nightly News and ABC and CBS, and I'm talking on the phone to the CBS medical correspondent, you see that there is an importance to be responsive to these large outlets. So they probably got the most attention and got to speak with our frontline experts. Then it goes to more TV stations at other markets that may have an interest. Boston was where Dr. Saker was from, so we had Boston Globe and Boston TV stations you're dealing with. So you start to look at what level of investment do these media outlets have, and like I said, you don't want to ignore the local outlets, but in a lot of ways it's easier to talk to them because they come into the press conferences and they're on site. They don't need as much as the folks who aren't there but are still wanting to cover the story. So you see the big names, the big names. You start to learn that certain experts like speaking with certain outlets more than others. You learn that certain outlets won't do webcam interviews. I mean, at the time we didn't have an on-campus studio to do satellite interviews, which we do now, so we had to shuttle doctors to other places off campus or to satellite trucks on the edge of campus to do these interviews, which can be time-consuming and tiresome and cumbersome. And so we would do just webcam live streaming interviews, which lots of folks were fine with that, but some weren't, and so you kind of prioritize that way too.
So Taylor, it sounds like this really was a huge job, and one of the questions that came up was, how large is your media relations team, and how did you divide up roles while managing this crisis?
So I have one other person who is essentially the same thing as I am. She does the same thing I do. She was here at the time. So she is the only other, quote, media relations person. We do have a marketing department who prepares internal publications and does a lot of other things as far as that goes. They were always willing to help whenever we needed them. On the university side, they have about 3 media relations people. So they were very helpful throughout this process too. So I guess as far as actual media relations people go, it would be myself, my colleague here in the Nebraska medicine side, and then 3 folks on the university side that were really heavily invested in this effort. Now, our internal communications manager also was helped with external communications too. So we had maybe 5 or 6 people that were closely involved with this communication effort. And so, like I said, when I knew there were things that I couldn't handle that we needed done to make sure the whole process would work, we were all texting together. We had a text chain that is so efficient and so rapid that you can let everyone know what you're doing, what you need, when you need it. And so we were checking the boxes, and everyone had a duty. Someone said, okay, I'll contact the folks with audio-visual to make sure the audio is taken care of. Okay, I'll contact the people, our graphic designer, so we can have placards made up for all the people who will be at the press conference. So there were a lot of tasks that needed to be done in a short amount of time, and everyone was just willing to pitch in and help out whenever they could, and we just were very fortunate in that regard.
Did any of the media questions surprise you, and if so, what was the most unusual request that you received?
One of the things that comes to mind is, and media is going to ask what they're going to ask. They're going to try to find any angle, and like I said, some questions I can ask and answer, and some I can't. The one that was a little bit interesting and unusual is they wanted to talk to the people and find out who the people were who handled all the medical waste coming out of the unit. And I quickly learned that the folks who handled that for us wanted to remain anonymous. And so that was just something that we couldn't talk about. We contract with these folks. They don't want their identity known, and so we can't share it with them. So that's the one thing that comes to mind that was a little bit unusual. I'm trying to think if there was anything else that I think that's the one that really readily comes to mind right now.
Did you have to involve hospital police to contain the media?
No, I don't think we did. Security is pretty good on campus here to know when media are going to be here and where they're allowed to be. We will call them on a regular basis and say, hey, X outlet is going to be here at this time. It's okay for them to be here. So obviously we just did that on a larger scale. If someone was wandering off, would we get a call? Yeah, but that just didn't happen that often in this case.
So there were a number of questions about discussing or clearing things with your legal department. How often did you meet with them ahead of time? How often did you have to meet with them throughout this process, or did you meet with them?
Since this has happened, there have been some unrelated to Ebola meetings with legal, but at this time, I can honestly say we didn't interact with them a lot. Executive leadership, yes. Highest levels of leadership and management, yes. We were always looped in and always letting them know. But legal was not something that we dealt with at that time.
Is there anything that you would have done differently looking back now, and has this experience changed how you respond to the media?
Yeah, there were. We would have probably early on made it even easier for media to be listening in and watching what was happening. I wish Facebook Live were a thing back then, because it would have made so much easier. You could provide so much to so many people so easily through your hospital Facebook page, which we do now on a regular basis. So we used Ustream at the time, which is you have a link and you can use it, and But early on, we didn't even do that in the first 1 or 2 press conferences. Once we realized how many people wanted this information, how many people wanted to watch what was happening and ask questions, we then had a 2-way conference call line at all of our press conferences. We had video so they could see what was going on. We would, even if we had just quick interviews with experts, I would set up a webcam and do a Ustream interview. So I wish we would have been a little bit more on the ball with that. That was just something we hadn't dealt with. As far as my view of the media goes, I don't think it has changed my view of the media. It reinforced the fact that we always got to keep the local folks in the loop, even when the national folks show up, because when the national folks leave, you'll still have your local reporters that you work with on a daily basis, so you just can't ignore them. Like I did mention, my eyes were open kind of quickly to how quickly what I said was everywhere, because social media is everywhere. That kind of thing, and you don't know the people you're talking about nationally on the phone. You get a phone call from someone at the Boston Globe. You can do a quick search and see who that person is, but you don't have a relationship with that person, and anything you say can and will be used against you in some cases. So that was one thing that was kind of an eye-opener that made me realize I probably shouldn't be as conversational or colloquial with these folks as I generally am with the folks I know.
A couple of questions have come up about, are there any strategies for responding to questions or comments from public or media that are racist or xenophobic or otherwise misinformed or inappropriate? Yeah,
like I said, that's kind of part of what we responded to on local social media channels. We didn't have a ton of these, but you did have the element of people who thought that we were either going to infect everyone, or this was just a hoax that we were making up, that we shouldn't be doing this, and there was some of that that we saw out there. And while I say we like to engage on social media, that's one of the things that I've done, even outside of a crisis situation, when our stories and our experts are in the media. I am happy to enter the conversation if I think I need to. The thing that I always keep in mind when I'm doing this is, while it's important for your social media channel to seem like a person, and because when it gets down to it, it's people operating it, to not be this big, all-knowing organizational entity. It's important to be personal and to be a human. When it gets down to those types of conversations, you have to be as formal and as upright and as righteous as you possibly can to just show what you're trying to do is for the greater good, and to not engage in the mudslinging, to not stoop to the level of the folks making those types of comments, to possibly address them, but do those in the most sensitive kinds of ways. And I think my colleague who I work with, who does what I do, she knows that I kind of take pride in doing that. That I believe that there's the conversation, and an open and honest conversation can turn folks around for the better. People who are angry about whatever they might be angry about, that if you just engage them and explain to them in a person-to-person way, with the accurate information that you have, that you can make them at least understand where you're coming from. And so I think there is a way to do it and a way not to do it. You just have to be very tactful and very appropriate.
Taylor, there are several questions that have come up about communications with the health department, and besides supplying answers for the health department hotline, how else did you work with the health department on communications?
We always looped them in on what was taking place. We had more of a relationship with them when monitoring the patients, because in certain cases, in certain groups of patients that were being monitored, they were monitored at locations at places off campus, kind of quote undisclosed locations, and it was really the responsibility of the local health department to do this monitoring. We provided medical expertise, but they were under the jurisdiction of the health department, and so there were a couple of times where questions were being asked about that, and it was really up to them to answer those questions. And so I would, closely communicate with their communications individuals, talk about, here's how we've done this in the past. Here's what I think would be a good approach. So, they kind of got put in our shoes a little bit, and so even though we were still involved, we worked pretty closely with them to work on messaging in that regard. But as you mentioned, we did have that hotline that people asked about, and so I was always talking with their communications expert over there to update them on new questions that we may want to add to that, new answers we had, and so those were really our main involvements with the local health department.
In order to properly prepare staff, what critical measures should be in place by the leadership team to ensure open, honest, transparent communication internally?
Repeat that question?
So in order to properly prepare staff, what critical measures should be in place by the leadership team to ensure transparent communication internally?
I think one of the things that you might need to do is emphasize with leadership about how important it is in this day and age to keep your employees and colleagues in the loop. It's just of the utmost importance that any large initiatives happening here on campus be shared with the folks who may or may not be involved with it, but who could be directly or indirectly involved with it. So I think it's important to guide leadership toward this tenet that we're in an information sharing age where this information gets shared very rapidly, and we want it to come from us first, not from somewhere else. You work for our organization. We need to look at these people as colleagues, and they're invested in the organization. They need to know that they're a part of this. And so if there's anything I would do, I would make sure that if we had something that we knew was going to be an external story, an external crisis type situation, I would just make sure that leadership knew how important it was to share this with staff first, because who wants to hear it from somewhere else?
So one of the questions that came up, and I apologize in advance because I think this is a really difficult question to answer, but how would you have responded to the Ebola outbreak if you were in West Africa or anywhere outside of the U.S.?
If I was a communications professional in West Africa?
Yeah.
Or if we were an organization in West Africa?
I think that's what the question is asking.
So if our hospital was located in West Africa and we're treating these patients?
Yeah.
Well, that's one I haven't considered before. I will say that. That would be much more difficult because, that situation was spiraling out of control in a lot of locations. And the facilities there just weren't as good. If we had the facilities there that we have here, the message would be similar. We're equipped to take care of these people. We have, the capacity to take care of these people. And so, but if you're caring for these people and you're working out of a United Methodist Hospital in Sierra Leone, that would be a lot more difficult. I don't know what how they even communicate over there. How readily available is the internet? How are people receiving the information? Not having been in West Africa, I can see how much more difficult it would be, and we certainly had a lot of luxuries here. So I guess I can't really comment on how exactly that we would approach that.
Several of the questions asked about basically communicating difficult information, maybe answering questions or giving information that people are not going to be happy to hear. How do you deal with that situation?
That obviously happened when Dr. Salia passed away, and so we had members of our care team who we assembled after that happened, and we had talked to the family, and they had granted us release to talk about Dr. Salia's case and what went on. And so we sat down and talked with those folks who, this hit them harder than anyone else. They were right there. Several of the folks, kind of were in the room through almost the entire, it was nearly 48 hours that he was here, trying everything they could to save him. And so we talked with them about, this isn't the outcome that we wanted. This isn't the news that people in Omaha are going to want to hear, or anywhere else for that matter. So again, it comes back to being honest and transparent about what we tried, how sick this individual was. Just being human is what it comes down to. And one of our critical care specialists worked right next to Dr. Salia for virtually the entire time, and he broke down in the press conference simply because that was how much it affected him. And we told them that this isn't the outcome we wanted, but we can share that information in such a way that lets everyone know that we tried everything that we could, and sometimes these patients are just too sick to be saved. That's why Ebola is so devastating. And being honest and human, again, I think goes a long way in situations where bad news is being shared.
So I think we have time for just a couple more questions. There was a question about handling the balance between providing objective information responsive to public interest versus also trying to advocate proactively in ways that might put pressure on legislators or regulators. Was that something that you thought about at all as you were providing information?
There was a little bit of a political climate surrounding this at the time. There were a few legislators locally who may not have been as in favor of bringing patients here as others were, and that wasn't something that we took much into consideration because we had a job to do. This was happening. This was why this unit was created. And in retrospect, it was really astounding that there weren't more units like this. There was us, there was Emory, there was National Institutes of Health, and that was pretty much it. Places that were able to handle these types of patients. So I think it really shined a light on our inadequacies there, and a lot has been done since then to train people and to prepare our healthcare system for the next thing. So I don't think, and at least I didn't hear that much about the political climate surrounding this, and so everyone just had a job to do, and they did their job and didn't think about that.
Well, Taylor, thank you so much for sharing all of your expertise and your experience with all of us. I think that this is really valuable information. The slides will be available and the recording will be available on the SHEA ORTP website, so people can look that up if they would like. Is there any last piece of information or advice you would like to give us?
I just appreciate the opportunity to share the message. And the thing about PR and media relations is that none of this is ironclad. None of this is set in stone. It's not written down that this is how you do things and you can't do them any other way, because things work differently for different organizations. This is what worked for us in Omaha, Nebraska. Our culture is what it is, and it may be different than your culture. So don't be afraid to try new things, to see what works and what doesn't. And I hate this phrase, but I'm going to say it. At the end of the day, to me, it comes down to not being stupid. I know that's very, very simplistic, and you see stupid things happen all the time. And I'm not saying that we weren't stupid in some of the things we did, but just if you go about things in a thoughtful way, being transparent, being proactive, being honest, open, helpful, attentive, I think you're going to be okay. That openness and that being helpful and being available goes a long way in these types of situations, because then people know you're there to help them. And once they know they have someone to help, then they know their job is easier and everyone's happier. So thanks for this opportunity. I hope it was helpful to someone out there, and have a good day.
Thank you.